Okay, thank you very much. So I'm going to start. We're going to talk a little bit about the guideline at the very end, which Rachel's going to present. I'm going to talk in a little bit more detail about submassive and massive pulmonary embolus. And I'm going to talk a little bit in terms of what the evidence is. So a little bit about my disclosures. David knows this because he worked with me on Sunday. I'm aggressive by nature, but I hate conflict. And when the hospital administrator came down to give us some grief, David luckily took me out of the loop and took care of the conflict. So I appreciate that, David. However, I have learned to chill out, and I've chilled out a lot on this topic as I've done a more deep dive into the evidence. And to be quite frank, I don't know if I have all the answers. So just to start off here, when we're seeing a patient with a possible pulmonary embolus and a possible submassive pulmonary embolus, that's what I'm going to talk about first. I think there's three important questions that we really have to prompt our radiologist the information that we need from them. Number one is, can you please tell me about the clot burden? I really need to know how much clot is there. Is there a lot of clot in both pulmonary arteries, or are we dealing with just a small little subsegmental nothingness PE? Because there has to be a clinical correlation between how much clot is there and what the patient looks like in front of you. And what I'm getting at is if a patient has a small subsegmental pulmonary embolus and they have right heart strain and a high trope, that patient may already have pre-existing right ventricular dysfunction, and that little PE is probably not the problem. And tell me a little bit about what the RV looks like, especially in relation to the LV. And this is talked a lot about in a lot of the studies, the ratio of RV to LV. So I need to know, does the RV look big to you, at least on the CAT scan? And the third very most important question, and it has a lot to do with mortality, is does the patient also have a DVT? So tell me about how much clot is there, what's the RV look like, and is there a DVT? Let's talk a little bit about the definitions. The definitions keep changing all the time. Some people are using more the nomenclature of low risk, intermediate risk, and high risk. Intermediate risk being the submassive and high risk being massive. So the low risk, really, you don't really have anything to worry about. The small segmental PEs, 99% of them will do just fine. And Rachel will talk a little bit about the management of those patients. The ones that we're a little bit more concerned about are the intermediate risk patients or the submassive. And I think I really like the new breakdown of intermediate risk patients in terms of, I know this is a lot of risk stuff. It's so low intermediate risk, which is RV dysfunction without any bump up in any markers, i.e. BNP or TROP, or high intermediate risk, RV dysfunction with elevated markers. And the reason being, again, is that obviously the high intermediate risk carries a much higher rate of mortality. Thirdly, I think everybody knows this really hasn't changed since the beginning of time. Massive or high risk PE is persistent hypotension, systolic blood pressure below 90 with evidence of right ventricular dysfunction and clot load. Again, as David said to me the other day on Work Sunday, you know, people who come in with hypotension don't have a paper stamped on their forehead that I'm having a massive PE. So there has to be a clinical correlation. So what about POCUS? Again, as being one of the sort of guys who's probably at the low end of the skill level, I'm pretty decent at most of the easy stuff. I still struggle a little bit with, I'm sorry about my dog. Hopefully he'll shut up. I think there's a real role for POCUS in PE, and especially to sort of risk stratify our patients, especially the ones that we think are maybe in the intermediate or high risk range. So when you look at a healthy, this is just basically a diagram of the healthy right ventricle in a patient without a PE. You can see that the LV is much bigger than the RV. And then when you put a lot of clot burden into the pulmonary arteries, you have this, basically the increase in diameter of the RV as it relates to the LV. And then during systole, you get this McConnell sign where you have the free wall of the RV that barely moves, and you have the apex that contracts. And I maybe I'll ask Paul and David and the other gurus what the best view we should be looking at. Maybe I'll just ask Paul right now, since I see him right in front of me here. Would that be short axis, long axis, or does it matter, Paul?
Um, well, the more views you get, the better. But if you were to choose one in terms of how easy it is to get and how useful it would be for PE, I think the short axis parasternal gives you a nice comparison. It gives you a shape. I compare them to a donut and a croissant. And if there's a nice big donut, that's the left ventricle, nice and round, that's good. And a nice thin croissant, the right ventricle, that's good. If they're both bulky and big and there's a flattening of the septum, then that's a bad sign. So that would be the one I would go to if I had to choose, but I prefer to do more than one view.
Can you get much information from subxiphoid, Paul?
You can, but it can also be dangerous because a simple rotation of the probe can make the right ventricle look significantly bigger than the left just by turning the probe accidentally. So it's not really, unless you're making sure that you have swept through all the different rotations of your probe, you can get false information. So be very careful. It is good though for swiveling right onto the IVC and seeing if it's enlarged.
Exactly, which I'm going to talk about. Very good. Thanks, Paul.
I tend to use the apical full chamber view, which is this view here. And one of the reasons I do that is that it allows you to have a look at the tricuspid valve at the same time. Yeah. And one of the other signs is tricuspid regurgitation. So if you just put a color flow window over the tricuspid valve and you see a jet coming downwards into the right atrium, then that's another sign to look for.
Excellent. I agree completely with David. I was thinking in terms of the easiest view to get, I was weighing that in. But yeah, if you can get this is the prime view for sure.
Yeah. So, and I think Rachel and I were talking about this yesterday. And again, some of us are okay at getting these views, others not. But I think we have a cohort in our group they can do this very easily. So we know that emergency medicine is a team sport. So if there's somebody else working with you and you're concerned, I think just asking for somebody to take a look for you, I think is appropriate. So again, just this McConnell image here on ultrasound, basically you can see diastole and systole, where you can see the apex. It's not the best view, but you can just see the apex, how it's contracting, and the free wall of the right ventricle is not moving at all. So this would be certainly a sign of right ventricular pressure dilatation. So here again, another view here. This is a more ominous sign, and I really apologize. Let me just get that dog. Just a second. Prezi, stop.
This is the short axis view.
Yeah, thanks, David.
Yeah.
So on the left-hand side, you've got this very happy-looking left ventricle. And on the right side, you've got this very ominous D sign where you have the very dilated right ventricle, and with the septum pushing into the left ventricle, giving you that D sign. So this is a patient in big trouble with right RV pressure. So I think what I'm getting at is I really believe now that everything I've read now that POCUS is probably going to be a big utility for us for risk stratifying these patients, the patients who are in trouble or are getting in trouble, or conversely, they're not in trouble at all. So about 30% of patients that present with pulmonary embolus will have some degree of right ventricular dysfunction. Of those, 10% will progress to shock, and a total of with a 5% mortality, hospital mortality. So it's just trying to sort of risk stratify which of those patients with RD dysfunction are most risk for going on to having a bad outcome. And I really like this graph here, which kind of illustrates the stratification of the right ventricular dysfunction. And if you look here, again, at this area here, a little bit of RV dysfunction, maybe obviously no bump in any markers. Most of these patients do very well, just with heparin alone, and they will do fine. I think the patients that we really should be concerned about, again, is trying to identify who these patients are, when all of a sudden the mortality curve starts to go exponential. Because by the time they're in shock, by the time you go from intermediate to high risk, the horse is already out of the barn and the patient's mortality goes up exponentially. And again, we know once the patient arrests, basically it's a really bad scene. So trying to sort of, how do we potentially do something to these patients, maybe unload their RV, such that they don't progress onto this, and trying to identify which those patients are. So what about morbidity? So there's this syndrome called chronic thromboembolic syndrome with pulmonary hypertension. This is persistent pulmonary arterial blood pressure above 25, 6 months post-PE. What's very interesting is the incidence is very, very low. It's only about 3%. And this is long-term data. This is from patients that over the course of many, many years didn't get thrombolysis or just got standard heparin, which is still the gold standard. So it's amazing how the body can still somehow organize the clot, take care of the clot, such that later on, the majority of patients do very, very well. The second syndrome is called post-pulmonary embolus syndrome. And this maybe affects upwards of 30% of patients. It's described as sort of a non-specific dyspnea. Some patients have difficulty doing what's called the 6-minute walk test. And I did a lot of reading on this, and it's really hard to define what the exact pathophysiology of this is. It doesn't seem to correlate with pulmonary arterial pressure. So there is some concern that there may be an issue of deconditioning that some of these patients have after this condition. And remember, most of the studies, as I talked about with the rounds with radiology, these are usually, the average age of most of these patients are the mid to late 60s. So 3 years later, we know that the RV gets, even though it's not RV, but a lot of these patients decondition anyway. So I don't know what to say about that yet. So these are our options for submassive pulmonary embolus and for non-massive for that matter. So we have heparin alone, which really has been working well for us for probably 50 years. And we know 90% of patients will do just fine with heparin. And then we've got IV systemic thrombolysis and try to identify which patients might benefit from that treatment. We also have catheter-directed therapies, either catheter-directed thrombectomy or catheter-directed low-dose infused thrombolysis, usually 24 hours. So basically, you put the wire into the clot and you infuse over 24 hours, usually in the ICU. And fourth, which is getting a little bit more back into vogue again, is surgical embolectomy. And this would be primarily for your sickest patients, your massive PEs. And I would put a caveat within that option, which is not there, is ECMO, which probably would marry very well with surgical embolectomy. So this was the biggest randomized controlled study looking at thrombolysis in intermediate risk pulmonary embolus. And these are intermediate high risk. Excuse me. So these are patients who have RV dysfunction and also have positive troponin, a significant positive troponin. And they standardized it, randomized it to full dose TNK versus standard heparin. Why they chose to do full dose TNK, I think was probably a big problem with the study. It was a company-sponsored study. They used an endpoint of a composite endpoint of death and hemodynamic decompensation, and the safety endpoints were major bleeding and intracranial bleeding. As you can see from the results, the composite endpoint was actually quite favorable to the TNK group. 2.6 either had death or hemodynamic decompensation versus 5.6 of the heparin group. The problem is, and I heard the great chief investigator, who was a nice, really very articulate guy from Greece, said, yes, it worked, but there was a price. So the price was a lot of bleeding. Not a lot of bleeding, but certainly more bleeding in the TNK group versus the placebo heparin group. And most importantly, there was a 2% rate of intracranial bleeding versus 0.2 in the placebo heparin group. The flaws of the study, again, mostly had to do with why they used full dose TNK when there had been some evidence, at least 4 or 5 years before this, that half dose TPA was safer and just as effective. So there was an issue of that. The other issue is they were using heparin infusion through the whole TNK dosing. So when you got the bolus, they continued the heparin all the way through. There's a lot of evidence to say mixing the two and continue to just basically increases your risk of bleeding. So it looks like, again, from this, yes, it works. When you look at the actual data, It works more in terms of patients crumping from going from stable to unstable. The death rate were fairly similar in the two groups, but certainly less patients are going to crump if you TNK. The issue is a lot of people are going to bleed. So having said all that, they said, well, listen, maybe this didn't work out so well, but I bet you we're going to have a really great effect on long-term morbidity because we opened up their pulmonary arteries, we got their pressures down. And what they found at 3 years is there really wasn't a big difference. Now, again, these were older patients. Again, all PE studies are almost always mid-60s. There was 20% of patients died in both groups, the TNK and the placebo group, not related to their actual pulmonary embolus event. When you look at the bottom part of that table, the systemic pulmonary artery pressures were very similar 3 years post follow-up in the order of 30, which is a little bit high, but most of those patients were fine. The rate of chronic pulmonary embolus, pulmonary hypertension was the same in each group, again, about 3%. So here we are, we're in a situation now, and again, some probably recognize some of these pictures that I took off the internet. We're at a state now where in emergency medicine, as we tell all of our learners all the time, is all I care about is acute, life-threatening, reversible disease. What can I do to save your life right here in the emergency department? Ideally, I'd like to think that I can do what I'm going to do today is going to have a big effect on your long-term morbidity. It looks, at least from the Plato study, that that's probably not true. Again, that may pan out to be differently, but right now it looks like thrombolysis in terms of the instance specifically of pulmonary hypertension and chronic thromboembolic pulmonary hypertension doesn't make a big difference. So our job is really trying to ascertain these two patients, and is there something that we can do to help these patients? So you've got the one patient who's teetering on the edge of the cliff. This is, again, a patient who's still a submassive. He or she still has a good blood pressure, but are there other features that says it's not going to take very much for that person to sort of crump, hypotension, shock, die? And you have the other patient who's just waiting to have another embolic event to finish off what is now a reasonably pulmonary hypertension that he or she can handle, and the subsequent emboli is going to put them into problems as well. What's been very interesting, when you look at all comers in terms of mortality of patients who have concomitant DVT, their mortality goes up a lot. So that's why I talked about when you talk to your radiologist about clot load, RV, if they have a pre-existing DVT, concomitant DVT as well, you should be way more worried, okay? Because they're just waiting to flick another clot. So when you look at all of these studies, the odds ratio certainly shows you that the presence of a deep DVT increases the mortality in patients with pulmonary embolus. So this is how we should think about our RV afterload with these patients. So again, just think again, go back to the clinical scenario, the CT result, how much clot load do you have? Is that really responsible for the RV dysfunction? If it is, then you start to go into this very, very death spiral of dilatation, neurohormonal activity. And then when you get about almost halfway around the curve, you start to get myocardial ischemia. The dilatation and pressure start to really compress on the right coronary arteries. You get ischemia, you get even poor RV contractility. You start to push into the LV, which further affects the preload of the LV, low blood pressure, cardiogenic shock, die. This is just a nice little diagram, what's called the pulmonary embolus death spiral. Again, it all comes down to you're not going to die from a respiratory arrest from PE. You're going to die from a heart arrest, primarily related to initially your right RV dysfunction impeding your left LV function. So knowing all this, and if we're going to consider that there are some patients that may be candidates for thrombolysis, which agent should we be using? And I think the data would suggest of the last 20 years, it looks like TPA is probably the one that we should be using. The other question is, what dose should we be using for TPA? Should we be using our cardiac dose, which we used a few years ago, 100 milligrams, or should we be using half dose, 50 milligrams? And Yang showed this 10 years ago that using 50 milligrams was no different than 100 milligrams in terms of lowering pulmonary artery pressure. And that's really our end game here, is the thrombolysis. You're not going to, as anybody who went to the rounds 2 weeks ago, when Chris White showed, when he did the surgical endovalectomy, you can just see there's a huge clot load there. There's no way we're going to dissolve all the clot. All we're trying to do is dissolve a little bit just to increase that RV, unload the RV so it can start being better. So 50 is equally as effective as 100 for pulmonary embolus. What about the rate of intracerebral hemorrhage? Again, you have to take this at face value, that this is more of a meta-analysis looking at a whole bunch of trials using low dose Adaplase or TPA. And you can see the incidence is very low. Again, these aren't consecutive patients, so you can't necessarily say this is the be all and end all, but it looks like low dose TPA looks very, very safe. Certainly lower than the high dose TNK, which had a rate of 2% in 500 patients. When you take all the evidence for patients with intermediate risk pulmonary embolus or submassive pulmonary embolus treated with thrombolytic versus anticoagulation, there's probably the odds ratio favor slightly thrombolytic therapy. Before I get into the sort of I'm just going to talk a little bit about catheter-based treatments. So catheter-based treatments, I think, are a really good consideration for your sick patients when there's a contraindication to systemic thrombolysis. The problem with all of them is all the papers are mostly been compared to heparin alone. There hasn't been a thrombectomy trial or a catheter-based thrombolysis trial that has been compared to systemic thrombolysis. So we don't really know. I can say this with certainty, they all work, and they all work very well. So they all can decompress the right pulmonary artery by removing clot or dissolving clot and bringing your pulmonary artery pressures down. The new thrombectomy device, the TriFlower, looks really impressive. We don't have it here in St. John. There is a number of trials underway looking at systemic thrombolysis versus these devices, so time will tell. But I think when you think about if you have a patient that recently had brain surgery or just had a spinal fusion or something that would be an absolute contraindication to thrombolysis, our IR people can be very helpful with these patients when you think it's warranted to unload their RV. This slide is just trying to illustrate that not all submassive pulmonary emboluses are created equally. There is definitely a risk. There's a low risk group and their high risk group. And we should really be looking at the high risk groups in terms of patients that we might consider doing more advanced therapeutics. So I'm just going to show this little graph here. Again, this is, I'm going to just, if I can just get this minimized here. So this is just a little bit of a template. Again, this is not in our guideline. I think this is just what I want people to think about. And I'm going to talk about multidisciplinary approach too shortly. But when you have, again, high risk, high intermediate risk patient, i.e. RV dysfunction, positive trope, and everything else correlates well together. And what I mean by that, again, the radiologist tells you, boy, there's a huge clot load in both pulmonary. It makes sense because you always have to think about, is there something else going on? Is the patient having an MI? Is the patient septic? Is the patient hypovolemic? So big RV, and I think to Paul's point, very, very important, which I should have stressed more at the beginning, you really need to look at the IVC because the IVC should be just juiced, should be barely moving with a pulmonary embolus. So when you go anything below intermediate high risk pulmonary embolus, most of them are 95, 98% of them are going to do just fine with heparin or NOAC or whatever you want to do. It's the ones with RV dysfunction, positive tropes that you should be a lot more concerned about, especially if they have a DVT. Those patients we know are a little bit more high risk. You should consider maybe thrombolysis for those patients. The other group is what they call the hemodynamically unstable submassive, and they're not unstable because they have a bad blood pressure. Most of these patients still have a good blood pressure, but they really are unstable. They have very, very poor RV dysfunction, marked RV dilatation that's impeding left ventricular filling. They have a shock index of greater than 1. Syncope is a very, very bad risk factor for pulmonary embolus. And the young woman that I presented at rounds who passed out twice, she's just telling you that her RV can take nothing. So probably laying her down is going to be a big problem for her. Lactate, I know we order a lot of this. This is very helpful as well, just telling you that you have a lot of anaerobic or ischemic injury going on. And there is a little bit of a clinical gestalt here as well. So the patient looks crappy, they're pale, they're diaphoretic, I feel like I'm going to die. Again, coming down to everything again, does everything correlate? Does the clot lobe make sense? They're not hypovolemic. The IVC is jugged. The POCUS looks like this is really bad RV dysfunction. It's the real deal. Those patients, we probably should consider low dose TPA as well. I'm going to talk in a few minutes about massive in a minute. Oops. Oh, sorry. There we go. Okay. A couple of other tips with submassive pulmonary embolus. Again, as a general rule, if we're going to consider thrombolysis, we really should just consider it for the patients the greatest risk of dying. Okay. So low risk, intermediate, the majority of them, 98, 99% are going to do fine. The high intermediate risk, very, very, their risk of mortality is probably about 5%. The other important thing is trying to ascertain, is this really an acute pulmonary embolus? So the patient that presents with, like my young lady I had that day, she's on the treadmill, boom, she goes down. She walks up her stairs, boom, she goes down again. Unlike the patient that's been smoldering along for several days, that patient probably, the literature would suggest, probably won't do well with thrombolysis despite having right ventricular hypertrophy or dilatation. Their clot is probably organized. And to be honest with you, that patient has already gone that period of observation where they have shown that they haven't crumped yet. The other important issue, again, is when we're mixing all of our drugs, if we're going to use unfractionated heparin, make sure if you're going to give thrombolysis, you stop it through the infusion with the TPA and restart it without a bolus after the thrombolytic is done. So the logic would dictate, again, if your predicted mortality from a P exceeds the predicted mortality from lysis, then you should probably, and I should have put in brackets, you should probably consider thrombolysis, okay? So a young person, less than 65 years old, no contraindications of hemorrhage. They have a big dilated heart, their enzymes are up, they look crappy. That patient is probably they have a 10% chance of crumping very shortly. Their mortality is 5%. The risk of them having a major intracranial hemorrhage is probably less than 0.5%. So I think those are the ones that we should at least consider. There's a lot of talk about watchful waiting versus preemptive thrombolysis for these patients. And when you talk to a lot of seasoned ICU people, sometimes when they crump on you, it turns out to be awful. Like it's just they're a lot sicker. The thrombolysis doesn't work as well. So sometimes just doing it, front loading it kind of makes a little bit more sense. What about passive, it's not passive, massive pulmonary embolus? Again, clinical correlation, as David said, these patients will arrive usually by ambulance, maybe a friend will bring them. They're usually in shock. They have low blood pressure. Again, unfortunately, you're not going to be able to get these patients to the CT scan because they're too unstable. So this is where your POCUS comes in. You do your long, short, 4-chamber look. They got big RV dilatation. They got a D sign. You look at their IVC and it's just totally stoked. It's big. It's not moving. And then you have to do a risk assessment of what am I going to do? Am I going to give this patient systemic thrombolysis? Am I going to send them to IR and do a catheter-directed treatment? Or am I going to slap them on ECMO and perhaps think about a surgical embolectomy? As Paul talked about at the beginning, there's a few things that we can do very early in the treatment of submassive pulmonary embolus so that we don't kill them, which is very easy to do. This is kind of like an asthma patient where, again, they got such big right ventricular or right heart pressures. You have to really think through what you're doing. Maybe this might be that I'm sure Jay will eventually do probably already has done a simulation on this type of problem. So the first thing is be very, very cautious intubating. And if you don't have to, you can probably delay it if the patient is doing well, oxygenating, not having any problems with their airway, because it's going to be fraught with a lot of problems. If you do have to do it, again, I like this slide, how to intubate without killing them. You want to use a cardio-stable induction agent, probably ketamine. You want to avoid anything that's going to crump their blood pressure. When you do your ventilation settings, they should be low tidal volume. You just want the oxygen just to be normal CO2, and you really, really want to avoid any pressure support. And you want to have your bag of drugs ready to go post-intubation, norepinephrine. There's some evidence that nitrous oxide as well is a good pulmonary vasodilator as well. Whether we do pre-induction art line, probably not a bad idea. I know we don't do a lot of those, but at least you'll have a really good idea of hemodynamically where you are. And again, these are rare patients, but these are the sickest ones. The other issue is be very, very judicious on the amount of fluids you're giving these patients, because these patients are already stuffed. Okay, so their hypotension is not related to a fluid problem. The hypotension is related to the RV is overloaded, not with fluid, but with pressure. So giving them a liter fluid may just, again, as this diagram illustrates, just get further dilatation of the RV, more impaired LV dysfunction, and worsening your problem. So super careful on the intubation. If you have to do it, delay it if you can, and really be careful about your fluid. So I think again, the POCUS is helpful here. You do this, it looks like you've got big RV dilatation. You look at her IVC, it's stuffed. Okay, this patient this is not a volume problem. So submassive, you're recognizing you've got this death spiral, you've done your POCUS examination. You're starting to think, how can I unload the pulmonary arteries, either by thrombolysis or thrombectomy? You're thinking about nitrous oxide. You're thinking about your inotropic support, usually with norepi and dobutamine. And again, intubate with caution. I think for the most part, as we go further and further down the road, and the more and more I read about this, I think this is the way of the future. And I think this is the way we should be thinking about these patients when they come in shock. The issue, again, is how fast can we get this going? So I think, I think I was talking to Jay McLaughlin last week about this. I think before COVID, I think we were ready to roll out with Chris White doing simulations, getting all the equipment in room 19. And this I think Chris said he could probably set this up within about 10 minutes time. So I think in the future, if this becomes more standardized, this is probably the thing to do. You call a ECMO code, the team comes, you do the 2 cut downs, you put the tubes in, and then you got time to think, okay, what do I need to do? Can I send them now to IR? Can I give them systemic thrombolysis? Or is the patient best served with a surgical embolectomy? So surgical embolectomy, just very quickly, again, the data on surgical embolectomy is based a lot on old data. And I've reviewed a lot of the stuff that Dr. White sent me. And really, it has gotten to be very, very good. Again, my understanding from talking to the CVS surgeons, it's actually a very operation to perform. The results in case studies of patients with massive pulmonary embolus, the total mortality is probably around 5 or 10% versus 50% by just doing systemic thrombolysis. The best ones that do the best are the ones that are pre-arrest, pre-CPR, and thrombolysis. So again, just activating, getting them on ECMO right away. And once you got them on ECMO, you can stand back and you can take a few minutes to sort things out. And I believe, I think this is probably going to be the best way to manage massive pulmonary embolus in the future. I'm hoping, again, and I think the initial rounds we had with IR, CVS, ICU, and IM, I think this is the way we probably should be looking at this as a team sport. Ideally, having a group discussion on what the best management is for our high risk, intermediate, and our massive pulmonary emboluses. Again, multidisciplinary approach. And I think that also, and as I talked about in the talk, it should be a patient approach too. I think if you say to a patient, you have a 10% chance of dying, you have a less than 1% chance of having an intracranial hemorrhage, you know, again, what risk are you prepared to accept? Rapid access to ECMO, again, for PE plus or minus surgical pulmonary embolectomy, I think is probably the way we should be going for our massive PEs. On that note, I will stop and